This is the PowerPoint from Chapter 4 in your Physical Rehabilitation for the Physical Therapist Assistant book by Cameron on posture. First, we're going to go through some definitions. The center of gravity is the point at which gravity and the weight of the body act on one another to maintain equilibrium. This is located slightly anterior to the first or second sacral segment. The line of gravity is a vertical line through the center of gravity to the floor. Center of mass is a point that is at the center of the whole body mass, and it changes with the position of the body. For example, this female is raising her arms, so the center of mass rises. And then when her arms are down at the sides, it lowers again. So you can see that if a person is supine or prone, their center of mass is very low. The base of support is the area of the body in contact with the supporting surface. As you learned in functional mobility, if you stand with your feet at a diagonal, you're going to have a much better base of support, and this is beneficial when you're transferring your patients. Posture is the alignment and positioning of the body in relation to gravity, center of mass, or base of support. Postural orientation is the ability to maintain the appropriate relationship between body parts and between the body and the environment during the performance of a task. Good posture is also called ideal posture alignment or neutral posture, and this is the position in which body weight is positioned over the base of support. Poor posture results in increased strain on the supporting structures and inefficient balance over the base of support. Here this patient is standing in anatomical position, and this is good for referencing planes and axes, but this is not the way we assess posture when we look at our patients. It is not the position of ideal alignment. However, this is used as a zero when we talk about range of motion measurements. So why do we study posture? Good posture is a state of musculoskeletal balance that protects the supporting structures of the body against injury or progressive deformity. When we look at posture, we look at relative alignment of all of the body parts. We look at relationships of the body parts to each other and to the body's base of support. We look at posture statically and dynamically. When we look at it statically, a person is remaining in one position, such as sitting or standing. When we look at it dynamically, the person is moving, such as when they're walking or running. Posture is controlled by the central nervous system. The central nervous system integrates information from the three primary systems: the visual system, the vestibular system, and the somatosensory system, which includes the proprioceptive system. There is no universally agreed upon ideal posture. Everybody's posture is a little bit different. So good posture allows the body's weight to be centered over the base of support. It permits efficient mechanical joint action. It limits wear and tear on joints. And we do look at static postures when we're looking at our patients originally. We look at standing, sitting, kneeling, quadruped, prone or supine, and possibly in a squatting position. Now we're going to talk about what ideal alignment is. So when you're looking at the anterior view, you see that the eyes are level horizontally, the shoulders are also level horizontally. The superior angle of the shoulders is slightly below the horizontal axis through T1. The scapula are flat against the thorax. There's a 30-degree angle anterior to the frontal plane, and they are approximately 6 inches apart or 3 inches on either side of the spine. And the medial border of the scapula are parallel to the spine. The elbows are neutral or maybe in a slight carrying angle for males and a slightly larger carrying angle for females. The wrist remains in neutral. There's no flexion or extension. The hands face medially towards the body. The ribs and lateral contours of the rib cage are symmetrical. The infrasternal angle is 90 degrees. The ASISs and PSISs are horizontally level. The hips are in neutral rotation. They're not in abduction or adduction. The patella face directly forward. The popliteal creases face directly forward. The Q angle is approximately 14 degrees in males and 18 degrees in females. The feet are neither pronated or supinated. The toes are relaxed without varus or valgus. The calcaneus is in mild valgus. The spine is vertically straight and the occiput is directly over the sacrum. Now when you look at the plumb line, it goes through the lobe of the ear, through the shoulder joint, through the greater trochanter, slightly anterior to the midline of the knee, and slightly anterior to the lateral malleolus. From a lateral position, ideal alignment involves the following. There's slight lordosis of the cervical spine, but the head is supported with minimal muscular effort without any rotation or tilt or retraction of the head. Less than 1/3 of the humeral head is anterior to the anterior aspect of the acromion. The proximal and distal ends of the humerus are in the same plane, which is the frontal plane. The elbows are in extension or can possibly be in slight flexion. The antecubital fossa face anteromedially and the olecranon faces posteriorly. There is slight kyphosis, 34 degrees for adults and 38 degrees for adolescents. The contours of the rib cage are symmetrical and in the frontal plane. There's no rotation of the rib cage. Lordosis is 64 degrees for adults and adolescents. The ASISs are in the same vertical plane as the pubic symphysis. The knee is in the neutral position, neither flexed nor hyperextended. In ideal postural alignment, we're going to talk about the muscles around the spine. The abdominal muscles pull upward and the hip flexors pull downward. The back muscles pull upward and the hip extensor muscles pull downward. So the result is that the abdominals and the hip extensors work together to tilt the pelvis posteriorly, while the low back and the hip flexors work together to tilt the pelvis anteriorly. Here we see postural sway, which is the normal movement of a body from front to back and from side to side in standing. In ideal alignment, the person appears to be standing completely still, but is actually constantly swaying forward and back and side to side. This is greater in standing than, it's greater in unsupported sitting than it is in standing. The cone of stability is the approximate shape of the area around a standing body, with the small end of the cone around the base of support, within which stability may be maintained without changing the base of support. Now we're going to talk a little bit about sitting posture. There are 3 categories of sitting posture. There's anterior, middle, and posterior. So first we will look at anterior or forward sitting posture. There can be either anterior rotation of the pelvis or increased kyphosis of the spine. More than 25% of the body weight goes through the feet to the floor. The center of gravity is anterior to the ischial tuberosities. In middle or erect sitting, the center of gravity is directly over the ischial tuberosities. Approximately 25% of the body weight goes through the feet to the floor. In posterior sitting, the center of gravity is behind the ischial tuberosities. Less than 25% of body weight goes through the feet to the floor, and this is a position of greater intradiscal pressure. Both of the postures that you see here are recommended for people who are more comfortable when they're sitting with an increase in lumbar lordosis. The first one is active sitting. This person is sitting at the front of the chair. The torso is leaning forward. The center of gravity is anterior to the ischial tuberosities, and the lower extremities are actively supporting the weight of the body. The spine is in a similar position to the standing position. The second position that you see here is called perching. This person is sitting with an open thigh torso angle, which is greater than 90 degrees. You can see that there's lordosis. The spine is in the same alignment as in standing, and there's a wide base of support to stabilize the spine. This is a person sitting in a balanced chair. This is an ideal sitting position. It makes the person position themselves as though they were standing, and it maintains lumbar lordosis. Any sitting position involves more flexion of the hips and knees than standing. So many patients are more comfortable sitting with their knees below their hips, and this reduces intradiscal pressure. When the knees remain lower than the hips and the back rest is reclined, this maximizes the thigh-torso angle to help maintain the lordosis when sitting. This provides support for the lumbar spine when sitting. A reclining backrest is a good idea for people who need to have intradiscal pressure reduced, and it helps control back pain in sitting. Now we're going to talk a little bit about poor posture. There are modifiable causes of poor posture, and there are non-modifiable causes. Modifiable causes are things that can be changed. So examples of these would be differences in muscle length or muscle strength, changes in joint range of motion, muscle spasms, poor postural habits, muscle imbalances, some soft tissue shortening, pain, and fatigue. Non-modifiable causes cannot be changed. They include structural variations and damages to bones, joints, muscles, and the nervous system. Some anatomical factors that are non-modifiable are ligamentous tightness or laxity and bony anomalies. Poor posture in itself can cause changes, such as changes in muscle length. Shortened muscles will lose sarcomeres and become tightened and lose their elasticity. Lengthened muscles will increase sarcomeres, and there will be a change in the length tension property in these muscles. Increased weight-bearing stresses on joints result in deformation of cartilage, nutritional changes in the bones, and degenerative joint changes, which can lead to inflammation. Some conditions which contribute to postural changes can be seen here, such as pregnancy, osteoporosis, aging, ankylosing spondylitis, chronic obstructive pulmonary disease, and we'll even talk a little bit about hand dominance changes postural alignment. Some common postural deformities include forward head position, kyphosis, a dowager's hump, which is an anterior wedging of the thoracic vertebral bodies, and this is usually secondary to degenerative changes in osteoporosis. It's also lordosis, which is an increased anterior curvature of the spine, scoliosis, which is a lateral curvature of the spine, and we will talk later about sway back and flat back. Some other postural deformities you will see will be coxa valga. This is an increase in the medial angulation between the neck and shaft of the femur. Coxa vara, which is a decrease. Genu valgum, which is also called knock knees, and this is a medial tibial-femoral angle that is greater than 185 degrees. It causes increased tensile forces on the medial condyle. Genu varum, which is also called bow-legged, there's a medial tibial-femoral angle of 175 degrees or less, and this causes tensile forces on the lateral tibial condyle. Genu recurvatum is knee hyperextension, and lateral pelvic tilt occurs when one hip is higher than the other and the spine curves with convexity towards the lower side. Here you see how pregnancy affects the spine by increasing lumbar lordosis, increasing anterior pelvic tilt, and there will be a posterior position of the head. Osteoporosis causes excessive thoracic kyphosis, and it alters the elastic properties of connective tissue, causing loss of strength, flexibility, range of motion, and in gait pattern. I'm going to stop.